Good evening, everyone. If I can have your attention, please. Thank you, Chris, for that alarming bell. Hi, I'm Kevin Lyons. I'm the Executive Director of Rheumatology Nurses Society, and I would like to welcome everyone out tonight to San Diego. And we have some people coming in a little bit. That's fine. Come in. You're welcome. This is an informal event. Please sign in, and Scott will help you out. We also tonight, we had such a great response for this evening on this program. We are also live streaming this to some of our other members of Rheumatology Nurses Society. So this is actually going out on the internet. You'll be able to see a replay of it. So we'd like to welcome everyone who's logging in through Google. You've joined us tonight as well. Tonight, with you out what our patients are asking us about rheumatoid arthritis. A little bit of background with Rheumatology Nurses Society is we're a brand new specialty when you think about the scope of nursing, brand new being we're only 8 years old. So Rheumatology Nurses Society came into existence 8 years ago. We are a nonprofit association. We are a membership-based association, and we have somewhere around 700 members currently across the country. In 2012, we were recognized as a specialty by the ANA, the American Nursing Association. In 2013, we co-published the scope and standards of practice for rheumatology nursing with the ANA. That was a very important step for us to take to propel the specialty of rheumatology nursing. That was a big deal for us. In 2014, we recognized that there was a need of specialty certification. So we partnered with the American Nursing Credentialing Center, the ANCC, and we are actively developing certification for rheumatology nursing. And that will be a portfolio-based certification, which is a little different than the exam-based. Because the specialty of rheumatology nursing is so new, we've partnered with the ANCC and really discussed that a portfolio-based would be a better exemplar of what a qualified, competent rheumatology nurse would be. So there's more information about that on the RNS's website, which is rnsnurse.org. Or if you want to come up afterwards, I can answer some questions, but we direct most of those to the ANCC. In 2015, we recognized the need of developing the body of knowledge for rheumatology nursing. So we actually published the core curriculum for rheumatology nursing, which is a 484-page textbook with 27 nurse authors. And this goes throughout the lifespan of a patient in rheumatology, and that's across all rheumatologic diseases. It talks about all the biologics. It goes into treatment options from juvenile all the way up through geriatric, including special conditions, advanced diseases. So Rheumatology Nurses Society is comprised of both RNs and NPs. So we recognize both of those within the scope of practice. We also have membership that's open to non-RNs and non-NPs. So we actually do have PAs and MAs and LPNs. They're associate members of RNS because we found that we share a lot of the like needs of knowledge that's out there. RNS also has an annual conference that we do. We just finished up in August. It felt like it was yesterday. We finished up in August in Orlando. We had over, I think, 240, 250 rheumatology nurses out for 18 and a half credit hours of just intensive education in rheumatology nursing. Pediatrics were covered. Pharmacology was covered. We had all types of just amazing content that was out there. So take a look. We have our next conference in Cleveland in 2016. And in Cleveland, we are going to have another 2.5-day conference. We're probably going to have a pre-conference, which will be an immunology boot camp. We have speakers like Dr. Grace Wright, Dr. Lynn Calabrese, but we also have amazing nurse speakers like Iris Zink, who is our current president of the RNS, which you'll be hearing from a little bit later tonight. She is a nurse practitioner out of Lansing, Michigan, as well as Linda Merritt Gimmel, is a Grimmel Gimmel. Grinnell Merritt. She and I, we love each other, but I butcher her last name every time. So that's right. We could say Derek. We could say Derek on there. That's for Brent. Wasn't Brent's fault. So anyways, Linda's going to be sharing with us. She's our president-elect of Rheumatology Nurses Society. She is a nurse practitioner out of Rochester at the University of Rochester. We have a board of directors, and we have many, many amazing nurses that are part of our team. So I don't want to delay too longer. A couple of the P's and Q's of tonight. One, as I flip these things around, I need a Vanna. Okay. So on your table, you're welcome to take these. This is the Rheumatology Nurse Practice newsletter. The newsletter is a evidence-based, peer-reviewed newsletter that we produce. And this is our 3rd edition, amazing content that's welcome for you to take. We also produce this guide, what our patients are asking us about rheumatoid arthritis, handling the hard questions. This is the evidence-based facts behind some of the information you'll be hearing tonight, as well as some other information I think will be really valuable to us. On our website, we have both free for non-members, but also members have access to things like meaningful use documents and other educational materials. So we really encourage you to come out and visit our website. We also have a couple of new things coming up for certification in 2016. And then we also have coming up pretty soon, we will be in the accredited provider, which we're working on, so we can issue some of our own CE. Some of you have asked why we don't have CE for tonight. Tonight is actually sponsored by a grant from Pfizer, an educational grant. So this is an unbranded educational program. The grant did not specify for us to have CE, and we felt it was so important to get this information out to the nurses that we wanted to move forward without issuing CE. But we do have some programs coming up in the future where CE will be issued. If you look on our website, we do have online programs for free, even for non-members, where you can obtain CE in rheumatology nursing. So we invite you to do that as well. Tonight, you also have, excuse me, I'll borrow this. On your tables, you have a keypad. She's a much better illustrator of this. You have a keypad. There's going to be some questions throughout the night tonight where you'll respond by pressing the keys, and you press them really hard and you focus on this. Basically A, B, C, D, E, 1, 2, 3, 4, 5. So you press the keys to respond to the questions. We'll cue you in on that. We also, because we are live streaming, if you have some questions, and we encourage dialogue. This is not a sterile talking head presentation. This is a conversation that we want to have with you about what the hard questions are that our patients are asking us about RA. But if you do have a question, if we can, as much as possible, let's hand you this mic. The mic is not really projecting this too much. It's more so for the recording for the live stream. So without further ado, do you have any words of wisdom to share?
There are no wrong answers. The answers that you're going to put in, we just want what your opinion is, and then we're going to discuss each question. So there's no wrong answers. There's actually a couple of right answers on most of these. We just want to have a good dialogue with you about what your patients are asking you about and what answers you can get them. And if you have any questions, this is all about you. We created these slides hoping that we would answer the right questions, but if you have different questions, jump in. We want to make this very interactive, okay?
Awesome. Linda.
I got it. Can you hear me? Good. The hardest part was turning this on. So I told a couple of you guys already this evening, I'm in the process of transitioning from different contacts, so I can't see close up or far away right now. So I'm going to do the best that I can. So my name is Linda Grinnell Merrick, because it's very long and very painful. That's my name. It's a very long and painful name, so don't hyphenate if you don't have to. It makes your life a little bit more difficult. So I'm going to talk to you guys about interpreting lab values. So it's something we all do in nursing. Those labs come across the desk and we're looking at them, and sometimes you're just wondering, one, why did they draw these, and what am I supposed to do with these, and should I be concerned about these? So I'm going to try to answer some of that for you guys this evening. Certainly, if you have any questions while we get going, just raise your hand, just stop me. But most importantly, I want to thank you guys all for being here on a Friday night. Oh my God, I can't believe so many people turned out on a Friday night. And I hear Garth Brooks is like around, and you guys chose us, so thank you. I really appreciate that. And then I'll talk to you guys about forming chapters when I'm done. So these are the topics we're going to talk about this evening. We're going to look at, we're talking about rheumatoid factor, the RF. The anti-cyclic circulated peptide, I hate that word. They can't hear me? Oh, can you guys hear me back there? All right. So that's the anti-CCP, the anti-nuclear antibody, ANA, the erythrocyte sedimentation rate, also known as the ESR, or I just call it the SED rate. We're going to talk about the serum reactive protein, CRPs. We're going to review complete blood count. I know it's something we've all been doing as nurses for years, but we'll talk about that a little bit more. Liver and kidney function, uric acid, and the hepatitis profile. Now you guys can all hear me, so I can hear me. And we're going to begin first at looking at the immunologic antibodies. So I'm going to cover rheumatoid factor, anti-CCP, and ANA. And now I can really hear myself. So I began with rheumatoid factors. So we've kind of listed some normal values here. They may be a little bit different where you're practicing because all labs have their own assays. My values where I work are less than 10 would be a normal value. But we kind of pick kind of the median, what you might see. So rheumatoid factor are antibodies, which are proteins that are produced in response to an antigen, which is actually attaches itself, and I don't think this thing works so well, but it attaches itself on this little immunoglobulin on the F portion of that. And if you all recall, the immunoglobulin is like one of our biggest part of our immune system, the IgG. So the rheumatoid, what do you need to know about the rheumatoid factor? Why is it important in our patients? So it's elevated in only about 60 to 80% of patients who have rheumatoid arthritis. So that means there's a large percentage of patients that you're going to see who may not have an elevated rheumatoid factor, but that doesn't mean they don't have rheumatoid arthritis. And it's elevated in about less than 40% of patients who present to us with early rheumatoid arthritis. And I know in our clinic we have actually an early rheumatoid arthritis clinic. And so that we see people who have very mild symptoms and a lot of joint involvement. We try to catch them early so we can intervene early. So lots of them, when they present to us, may not have an elevated rheumatoid factor at that time. And the values can fluctuate over time, but for the most part, once you're positive, you're going to stay positive. And I know lots of my patients, we tell them, oh, you're in remission. This is great. You've been taking your meds and life is, things are going really well. And they want you to repeat this test because it must be now that this is really all good and all better. So we have to remind them that once it's positive, it's generally always going to stay positive, even when they are in remission. Sometimes we do repeat them if they're in clinical trials. So that's not to say they're not done again. And in our early RA patient, they're in our early RA clinic, we'll repeat them maybe once or twice every other year because they may turn positive over time if they were negative. But the other important thing to know about rheumatoid factor is that it's not necessarily specific for rheumatoid arthritis. It can be positive in other diseases such as lupus, Sjogren's disease, mixed connective tissue disorders. So it can be positive. It can be positive in other diseases. So it's not specific for rheumatoid arthritis. And now we do not have slides anymore. It can also be positive if you have infection, if you have malignancy, off the top of my head now, and in certain liver diseases, like primary sclerosing cholangitis. And there's one more. There you are. Thank you. And then it's positive in about 5% of healthy people. And then when you get to be a little bit over the age of 65, it can also be positive. And there's a stethoscope. Are you done? He's just trying to see how well I can do this. We good? Yeah. Okay. So, okay. I think we covered all that now that I've completely gotten over that one. And now we get to talk about the one I can't pronounce very well. And I like to call it anti-CCP, but the anti-cyclic circulated peptide. Again, we present some normal values here. Usually less than 20 would be considered negative. So anti-CCP antibodies, and this strictly is just for your knowledge and nothing I'm going to test you on later on. Our antibodies are directed against an individual's own proteins. They're directed against the citrullinated peptides and proteins. So what happens is during inflammation, you get these argine amino acid residues that can be converted into citrulline in a process called citronellation. And I'm not saying that again tonight. This is why you wanted me to go first. That's right. Oh, there I am. It's on delay. So we'll just try to keep going. So if their shapes are significantly different, the proteins may be seen as antigens by the immune system, and then they generate an immune response. And they will not test you, and that's not one of our hard questions later on. So anti-CCP are biomarkers that allow us to diagnose rheumatoid arthritis at a lot earlier stages. You remember I said with the rheumatoid factor, lots of times in early disease processes, it may be negative, the rheumatoid factor. This one's more likely to be positive in early disease. So we usually, when you're evaluating a patient, you're getting worked up and you're coming into your office for the first time, you would generally run the rheumatoid factor and you would run the anti-CCP. It's sensitive for RA between 50 to 75%, and the specificity is 90%. And so linking these two tests together, again, like I said, we run them typically when you first see a patient when they're coming into your office for an evaluation. Sometimes they're done by some primary care offices, or maybe you guys are working with the veterans. Some of that testing may be done before they come into us. A positive result for either test increases the diagnostic sensitivity, so a little bit more likely that they may have the disease. But if they test positive for both of these, it's much more likely that they have rheumatoid arthritis. We also know that their disease process will probably be more aggressive. Now, 50% of the patients, when we first see them, will probably test negative for both of these antibodies at presentation, and maybe later on will then develop. The antibodies will probably become present. But then we have about 20% of the patients that will never test positive. Their rheumatoid factor and their anti-CCP will always be negative. But that doesn't mean they don't have rheumatoid arthritis. It just means they have seronegative rheumatoid arthritis. And this is a chart that kind of just looks at both of these. What we see in seropositive is that they will either have an anti-CCP or a rheumatoid factor. Disease tends to be more aggressive. They'll have more joint destruction, more tender and swollen joints. Where in the seronegative patients, their rheumatoid factor anti-CCP are likely to be more negative. We have to be more observant of their tender and swollen joints. So now you're really looking at the clinical presentation in front of you, and you're monitoring their acute phase reactants, which is the ESR and CRP. So that's just a little bit how difference between these two. And have anybody kind of knew that there was seronegative or seropositive rheumatoid arthritis? Is that anything that you've heard before? No. So good. You learned one thing tonight. Hopefully you'll learn a little bit more. Oh, so I'm not the person to ask that. I work in an academic setting, and we do not use these biomarkers. I can tell you, Iris, on the other hand, works in a facility where they use it a lot, and I'll let Iris speak to that.
Vector is the most amazing thing. The patients, like you said, Linda said, the patients, now I'm taking this drug, show me that my rheumatoid factor has come down. Well, the rheumatoid factor doesn't come down. If it's 400 when they came in the door, it's probably still 400. The vector is the first disease activity measure. You all know what a hemoglobin A1C is. So it's the hemoglobin A1C of rheumatoid arthritis. It tells you where the patient is with their disease process. Are they controlled? Are they out of control? Are they having X-ray progression? It's a lab test that gives you a mild, moderate, or active disease score, basically. That not every practice can do because it's not available everywhere. But I know that Crescendo is who has the lab test, and there's the multi-biomarker. So it's 12 different biomarkers they look at to get a score to make a vector test. So there's more of these going to come out. Right now it's called vector.
Yeah, they're fairly new on the market, a couple years maybe now. And so not all rheumatologists are on board yet. And so I'm working in a practice where they aren't on board. They're all academic by nature, and they're bench scientists, and they're waiting for there to be much more proof. So it just sometimes depends where you're working. So then the ANA, the anti-nuclear antibody, this is what I'm told I'm the queen of at work because I get to see all the positive ANAs that come through the door. Frequently, this is a test that's done in probably your primary care offices, the VA. Patient comes in, they have some vague complaints. This hurts, that hurts, I'm sleepy, you know, a lot of fatigue, and can't really find anything clinically wrong. And they'll do this ANA, and it's, you know, kind of a test of autoimmune diseases. And if it's positive, it usually gets them, you know, through the door at a rheumatologist's office to be further evaluated. That's it in a nutshell. That's my little ANA thing going on. So ANAs are antibodies that develop in our immune system to help our body fight infections. If they're present in large amounts, it could be indicative of an autoimmune disease. About 1/3 of patients with rheumatoid arthritis will have a positive ANA. When foreign bodies are present or recognized, the ANA recruits all its helpers, all its proteins to fight off the infection, and we get the inflammatory cascade. Unfortunately, sometimes the antibodies make incorrect calls, and they identify self as being foreign, and then they start this inflammatory cascade and causing the body to attack itself. Yep, I was just going to ask that before I moved on. Well, I'm going to talk a little bit about gout later. So certainly gout is, rheumatologists and lots of primary care practices see patients with gout and are comfortable managing gout. Certainly lots of patients end up coming to rheumatologists. You know, we have some wonderful drugs out there that we sometimes push it a little bit harder. So we certainly do treat gout also. And unfortunately, our patients, unfortunately, are sometimes can develop rheumatoid arthritis and have gout. So, you know, so certainly we're sometimes treating them for both diseases. So they may have inflammatory markers, which is the next ones that we'll talk about. They could be sometimes elevated, but generally, you know, we're going to be following the uric acid. The gold standard with gout is to actually get a fluid sample and get those crystals, which is a little bit painful in the sore joint, but it's certainly the gold standard. So now we're going to talk, did that answer your question okay? Yeah. So now we're going to go on and talk about markers of inflammation, which is the ESR, the SED rate, and the CRP, the C-reactive protein. And you've probably all seen these joints at some point or other. Their joints. These are also known as acute phase reactants. So if you're going through some of your patients' charts, and if you see that mentioned in a chart, they're referring usually to the SED rate or the CRP. And they represent an increase in serum proteins that comes with inflammation and tissue injury. But they're not particular to any disease. So they're not particular to rheumatoid arthritis. Just because these are elevated doesn't mean your patient has rheumatoid arthritis. They could have any other acute disease or any kind of other. The difference, you know, is the So the SED rate, the SR, where I work, the normal value is generally 20. So anything above that would be elevated. And at the SED rates, actually, they use the little test tube, and it's actually, they measure the rate that the erythrocytes drop down in the plasma in an hour. So that's how they measure that. But again, that test, you know, has its own issues because it can be by in size, shape of the, and also we have one of our bench size decides tells me it's also dependent on the temperature in the room when they're doing the test, which wasn't anything I knew about, but something she was telling me about. It's increased with any kind of active inflammation, whether it's systemic, local, an infectious disease. It can also be increased in our older population and female patients, patients who have anemia, patients with renal disease, and also with our obese population. So sometimes when you're looking at these, you got to kind of take the whole picture into account, what's really going on. I have a physician, when she sees her patients, I'll just do this really quick calculation. It's a 90-year-old gentleman, and his normal SED rate, she divides that by 2, which would be 45. It's a gentleman that would be his normal SED rate for him. So not what the value that you're seeing may be recorded, because with older patients it can be elevated. If you're female, you add 10 to that. So it kind of sometimes helps a little bit when you're thinking about that and you're looking at these values and you're trying to see is something different. I also look at the patient's baseline. Where have they been running? Is it really elevated, or is this kind of where they, where they live in their with their SED rate? The next marker of inflammation is the C-reactive protein. This is the protein that's found in blood plasma that's synthesized by the liver in response to factors that are released by macrophages and fat cells. And the levels rise in response to inflammation. And again, it can be anything. So any kind of acute or chronic condition, whether it's bacterial, viral, rheumatic diseases, malignancies, injuries, tissue necrosis. And again, with age, everything rises with age, right? With age, it can also be elevated. So again, when you're looking at these, just kind of look at where the patient's been running. Is this really a change in their value? And there's some people, at baseline, they'll always may be a little bit higher. And that's okay. So just look at that. The other important thing to know is if somebody has had elevated SED rates and CRPs and you're treating them and we're hoping they're getting better, you'll see a response in the CRP first. And then the SED rate follows. That drops a little afterwards. So the CRP would be the first response. So that's a good indication that you're on the right track with treatment. And the complete blood count. Something nurses have been, I think since day one in school, right? First day of school, they started teaching us about the complete blood count. So we know that with the CBC, we're looking at, does the patient have anemia? Does the patient have infections? Does the patient have malignancy? And then their response to the treatments, are they doing well if we're treating their anemias, or are they doing well if we're treating their infections? And basically the CBC is looking at 3 cell types, the white count, the red count, and the platelets, and then each of their individual factors within that. So we'll talk about red cells first. In chronic disease, such as rheumatoid arthritis, the bone marrow has a difficult time producing healthy cells. So this develops anemia of chronic illness, and we see that with lots of other diseases, renal failure and whatnot. So your patients, generally, when they're not treated and if they're newly coming in, they may have some anemia. And then sometimes it's an indicator that maybe if we are treating them, that they need a little bit better treatment. They're not doing as well. And also we have to be careful because the drugs that we're treating them, another reason it's so important to monitor, is they can get bleeds. We're giving them NSAIDs and we're giving them prednisone, so they certainly can develop bleeds. So we have to be keeping an eye on these rates. So the red cell count kind of is just looking at the whole number of red cells that it's in a patient's blood. The hemoglobin is looking at the oxygen carrying component of that, and the hematocrit measures the percentage of a person's blood that consists of red blood cells. And all your values will be a little bit different, I'm sure, than what we have, but just kind of based on what your values are. And then we look at the white cells. It's not uncommon in patients with rheumatoid arthritis to have leukocytosis, so they have elevated white counts, which makes sense, that they have inflammation going on, so that makes sense. And also, their white counts have gotten better and they're doing really well, and you're monitoring their labs, all of a sudden you see that white count going up again. Maybe they're not doing so well, so maybe it's worth a call. Hey, what's going on? It could be they're flaring, or maybe they have another disease process going on. So it's always important to also touch base with the patient and see what's going on. Also, and this happens frequently, and sometimes it's the calls we get on the weekends, is somebody started somebody on prednisone, and maybe somebody didn't catch it, and suddenly you're seeing a white count that's spiked up. It's the prednisone that's causing that. More than likely, but make certain they're on it. Don't take it for granted that that's what's going on. They can also develop leukopenia, which is having low white cell counts, and lots of times it's because of the drugs we're treating them with. So we do have to keep an eye on that also. And there's an elevated, patients with RA tend to have elevated platelet counts, and thrombocytopenia, low blood count, platelet counts are unusual, but then again, there are medications we're treating them with that can cause a thrombocytopenia. So again, we just got to keep an eye on these things and kind of look at the whole picture. What are they taking and what else is going on? Any questions? No? So then the tests that you probably always see all the time, we're kind of going to the chemistries, the renal function, the hepatic functions, hepatitis, the uric acids, and why are we monitoring these and why are we getting these? So when we're first evaluating a patient, we really want to know what their renal function is. This is going to help drive what we may be picking for treatment, but then also having to do dose adjustment if they have any kind of renal impairment. So that's why we're doing that, and that's why it's important, and you want to keep track of that over time. Again, we're also giving them NSAIDs, and this can drive their renal function up. So we want to make certain, again, you just kind of keep track of their renal function over time. And I think we all watch liver numbers. If you've had any patients with rheumatoid arthritis, so they're probably at some point in time been on methotrexate or leflutamide or Reva. So we're always watching their liver functions. See, and at baseline, we need to know, is it safe to start these drugs for them? And then over time, monitoring to make certain that it's still safe for them to get these drugs. And you know, we have some patients that we tolerate a little higher liver function test because it's their baseline and they're kind of doing okay. But you just got to keep an eye on that because we either have to adjust treatment, maybe lower dosage of medications, or we have to change, you know, treatment completely. And the hepatitis B serologies are done usually at evaluation. I know we do them as soon as the first time we see the patient through the door because our drugs can cause havoc and reactivate hepatitis B, you know, our biologics. Because at one point or another, most people will probably end up going on some type of biologic therapy that Iris will talk to you a little bit more about. And uric acid, so where I work, we do that at baseline. First time the patient comes in, we're going to do a uric acid because we do have these people with early RA. They're coming in, they may have 1 or 2 joints, and you're going, is this RA or do they have gout? Sometimes you don't know, you know, so you're trying to put the whole picture together. So you're doing, you know, your rheumatoid factor, your anti-CCP, and you're doing your uric acid. You're trying to figure out what's really going on with this patient. And then, like I said before, they can have rheumatoid arthritis and they can also have gout. And I think we talked earlier, they can have osteoarthritis too, you know. They can have a little bit of everything. So lots of our patients are also on treatment, maybe with allopurinol or something. So again, another reason why we're monitoring that, you know, is therapy effective for them also. Any questions? And now we're going to put the pieces all together. We're going to figure this all out. So we got a couple of patients. I'll go through this quickly for you. There is an, I don't know, do you bring that up, the whole ACR criteria, diagnostic criteria? So Iris will talk a little bit more about this. But basically, there's a criteria by the ACR, American College of Rheumatology, that has guidelines that kind of help us diagnose rheumatoid arthritis because it isn't always, you know, straightforward. You know, a patient may have some elevated numbers, may not mean they have something. So there's some guidelines. So the guidelines, they have to get 6 points out of a 10-point system to qualify, you know, to be diagnosed with rheumatoid arthritis. And part of that is looking at their serologies, looking at what their rheumatoid factor is and anti-CCP. So this gentleman has, I'm going to say a gentleman, I'm being kind of sexist, maybe it's a lady. The rheumatoid factor is 75, so we know that's elevated. Anti-CCP is 55, that's elevated. ANA is positive. SED rate's 100, that's elevated. CRP is 60, that's elevated. Crit's low, 32. Hemoglobin's low and his white count's up. So he would actually score 4 points on this ACR criteria, so based on how many tender swollen joints he may have and how the duration of their symptoms would certainly be probably get to 6 points pretty quickly. So, you know, not that you want to say this without seeing the patient first, but it's very likely before you walk in the room and you're just kind of looking at this, you're going in, you're probably pretty certain that you're looking at somebody who probably has rheumatoid arthritis. Then our another patient, maybe we treated this patient, he's doing better. His rheumatoid factor is 12, that's normal. The anti-CCP is 67, the ANA is negative, SED rate's elevated, CRP is elevated, crit, yeah, it depends if he's male or female. I haven't made the determination. Hemoglobin, normal, white count, just a little bit elevated. So this patient probably has rheumatoid arthritis. Maybe we've treated him and he's starting to do better. Or maybe it's just a new patient starting to come in. Any questions? So now we have questions for everybody though, don't we? Do you want me to read them? I can read them. I actually love this. This is where you guys all actually get to interact. So now we're handling the hard questions. So get your little keypads out. This is participation. There's no right or wrong answers. Nothing's going to ring and ding and say you had the wrong answer. So these are questions that, and they're all in your, you have these little booklets here, and I love this booklets. All these questions we're going over this evening are all in these booklets, and these are great because you do get these questions all the time. And but they may not always come to their rheumatologist and ask these questions, but they may be coming to you in private practice or at the VA. So these are great things for you guys to kind of be aware of. So why did I get RA? And so some of the answers may be, did your mother or father have a RA? If so, that's likely reasons. If you think that's the right answer, do A. B, are you or were you a smoker? That's a likely reason. C, just bad luck. And D, we don't really know. RA develops for different reasons in different people. So pick A, B, C, or D. Again, there's no wrong answers. We can all talk about it. I don't think it lets you put in more than one answer, does it? No. I think we got everybody's in. All right, here we go. That's excellent. That's exactly what I would say. Good job. We don't really know why do people get RA, and that's why people can have rheumatoid factor positive, rheumatoid factor negative, anti-CCP positive, negative. We know smoking can predispose people, so their environment, if they've been around smokers, and certainly genetics. We don't know. We're still trying to figure it out. Good job. But, again, if you picked one of the others, you weren't wrong either because genetics plays a role. Nobody picked bad luck, but it is bad luck, right? All right. And I just got this question the other day. Newly diagnosed person who didn't want to be on his meds forever. Is there a cure for RA? So no, and there probably never will be. No, but once we refine the use of biomarkers, there will be. No, but we can try to halt the progression of your disease. And yes, our current therapies are as good as a cure. Log in your votes. I know. I'm waiting. There's a couple people. You aren't decided yet. We got dum-da-da-dum. There we go. Very good. You guys are excellent. Oh my goodness. Really, right now we can't tell them we have a cure, but we have excellent drugs, and Iris will talk about them more, that really can halt the progression of the disease and the destruction that they can get. Maybe you can say it's as good as a cure. If you can get them into remission, that's our goal. We want to get them into remission. And I don't know, maybe they never will be. I don't know. Yeah. And the biomarkers we're not certain about yet. So, is RA going to affect my life expectancy? That's a tough question. I always want to be, oh no. So, A, yes, your risk of death is 75% greater than the general population. Yes, your risk of death is 40% greater than the general population. No, RA patients live just as long as the general population, and it's too hard to predict an individual's life expectancy. Log in your votes. Couple more people. All in. Good. Wow. So I think you're all right. You are, there is data and statistics, out there that says that they have a 40% greater risk of dying, and a lot of it is, I think we talked a little bit about cardiovascular risk factors. They have higher risk because of cardiac-related issues. Lots of them are smoking. So yeah, there is data. And it is hard to predict. We don't know. Sometimes I tell my patients, I can get hit by a car just as well as you can when I walk out of here today. So it is hard to predict. So we really can't say for sure. There are some data out there that suggests that, their life expectancy can be a little less than the average people, but we need to treat all of them, not just their symptoms, but also looking at their cardiovascular risk and some of their, social things. Are they out there smoking? What are they doing? Weight, obesity, all of that. And are my children going to get RA? There's a 50% probability that they will. There's a 25% not unless they're around smokers regularly, and there's no apparent genetic link in RA. That's a tough one. Huh? Oh, phone a friend? I need to phone a friend. Can I call you? Couple people still deciding. Oh, are you reading it? That's all right. It's a tough one. Let's see what we think. Let's see what our friends thought. So that's pretty accurate, there's a genetic predisposition to it, but we don't know what role entirely that will play. And there's also, their environment. Are they living in a house where there's smokers, and what was the environment that they were brought up in? So, pretty much all those answers are good. So that was kind of depressing, though, huh? Sorry. I know. I'm sorry. That was a bummer to end up on. I know. I'm sorry. And so next, it's my pleasure to introduce you to my president. There you go. Okay, I got to turn this off first. Thank you guys for your attention.
First and foremost,
Turn me off.
I am the president of the Rheumatology Nurses Society, but I'm also a mom. And I know you came here to eat meat, so they're going to do another round of meat while I'm talking because I have 5 kids at home and it doesn't bother me. They're going to try to avoid the camera, hopefully come down the middle, so you may have to reach across the table to get your meat. So hopefully they'll come down the middle so it's not right in front of the camera. So don't worry, they're bringing more meat, okay? So I'm Iris Zink. I'm a nurse practitioner from Lansing, Michigan. I was an ICU nurse for 5 years before I became a nurse practitioner, and that's going to be a relevant story in a little while. I worked for 15 years in rheumatology for the same doctor. My doctor was a nurse before she was a rheumatologist, so that's why we get along so well. So I've been really lucky to work for the same practice for a really long time. I see about 20 rheumatoid arthritis, psoriatic arthritis, fibromyalgia, scleroderma, osteoporosis type patients every single day. It's awesome. And then I travel around the country speaking, which is cool too. Oh, they brought the meat. Yay, look. Okay. So we're going to do a medication update. The medications that we use in rheumatoid arthritis have gotten incredibly complex. We started back in 1998 with Enbrel. There was 2 drugs with Humira coming out in Remicade coming out in 2000, then Humira coming out in 2004. So we had about 3 drugs to play with. Now we're up to 8, and probably by the end of next year we'll have 15 biologic drugs to play with. So the complexity is really increased. So what are we looking at here? So on the right-hand side, we have a normal joint. On the left-hand side, we have a rheumatoid arthritis joint. So what we think happens, or how I explain it when I talk to my nursing students or my medical students who come through the office. Kevin's like, jump up and down. We're going to take a brief pause while everyone gets their meat. We're just taking a pause.
This is all my fault. We're going to take a quick pause. Enjoy the drink, or enjoy some steak like we're enjoying tonight. And actually, if you do come to Nurses Society live event, you too could be eating some steak tonight, some meat. And so But we'll take a moment to thank our sponsors at this point. So the educational program tonight is actually sponsored by a grant from Pfizer. However, the Rheumatology Nurses Society is actually sponsoring your meal tonight, and we're very careful about making sure that RNS pays for the meal as a way of generating audience where Pfizer is actually supporting us to develop the educational content. So we'd like to thank you all for coming out for that. Good for everyone? Good education, good content? Awesome. Looks like we have a couple more meat options coming in. All right, what's the favorite question so far? I was gonna, yeah, trick question. To me, it was amazing watching, will your children get RA, the genetic element of RA, and that's always, throws the audience when we ask that question. Does everyone like the audience response, the keypads? Is that a fun feature? Cool. Yeah, it's actually shooting over your head. So, yeah, so the sound, restaurants are always fun when we're actually doing the rheumatology nurse practice events, because sometimes we have quiet restaurants that we thought were going to be loud. Sometimes we have loud restaurants that we thought were going to be quiet. So it's always kind of a hard mix, when you get into that. So, all right, well, we're going to go ahead and kick it back off. Miss Iverson.
Okay, we're going to kick the meat guys back out. So if you want meat, grab them now, okay? So this is how I explain it to my students. I'm going to stay over here until the meat guys get done. So I explain it to my students like this. So for whatever reason, an alarm goes off in your joint, and your body decides that there's a foreign body or there's an attack going on. So your body sends in cytokines, white blood cells, macrophages, all these pro-inflammatory hormones to look and see what's really going on. Well, normally, if it's an infection or something like that, your body clears it. With an autoimmune disease, for whatever reason, your body turns on all this inflammation, and your cytokines, they keep cycling the inflammation. So I told you that I have 5 children. I have 3 children that I gave birth to, but I have 5 children that live with me because sometimes you just get extra, right? That happens. So my kids are 24, 22, 16, 15, and 11, okay? They're all female children. And tonight, I know, it's awesome. It's like a sorority house. So my fiance is with me tonight, Chris, who's also a nurse practitioner. And so Chris and I took 7 children to South Carolina on a road trip, okay? So now this is all going to relate because we're going to talk about cytokines. So cytokines, you're never going to forget what a cytokine is. So a cytokine is a protein, hormone-like protein. So it's a hormone-like protein that's constantly in communication with each other. So it's your interleukin-1, your interleukin-6, your tumor necrosis factor. Those are all cytokines. We all have cytokines in the room right now. If we didn't have cytokines, we'd all have cancer. We wouldn't be able to heal from illness because when you cut yourself, the cytokines get in there, they get the infection out, they help your skin heal, they help the wound heal. Okay, cytokines are super important. But people who have autoimmune disease have way too much cytokines. So cytokines, again, pro-inflammatory hormone protein-like molecule that's in our bloodstream that's constantly in communication with other protein hormone-like molecules. So think about my daughters with the Snapchat, the Instagram, the Facebook, all this social media, the tweet. My 11-year-old's tweeting. I don't even know what she's tweeting, but she's tweeting something, right? So that's like social media. So cytokines are just like that. They get into the joint, think that there's an alarm going off, think that there's some damage that they're going to repair. And for whatever reason, in autoimmune disease, they start attacking your own joint. And they start eating away the cartilage and eventually start eating away the bone in rheumatoid arthritis. So it's a hormone-like protein that's constantly in communication with other hormone-like proteins, and it just stockpiles them. It keeps calling them into the drama. You know how teenagers are. There's so much drama, so they keep calling them into the drama, and eventually your patients get these red-hot, swollen joints that they tell you are so stiff in the morning they can't move. And it's just because they have way too many macrophages or immature white blood cells and all these pro-inflammatory hormones talking into their joints all at the same time. So that's how we get the joint on the left, which is the rheumatoid arthritis joint, where you form a pannus. Well, we're all nurses. Most of us in the room are nurses. When somebody says pannus to me, I think I'm going to go clean under something, right? So a pannus is just a thick layer. So your joint forms a pannus where instead of the nice synovial lining that's supposed to be inside your joint, it gets thick and boggy, and that's what happens with rheumatoid arthritis. So this is what we're trying to prevent. These are erosions where it's like Pac-Man took a little bite right out of the joint. So we're always talking about, oh, she already has 3 erosions. Oh my gosh, we don't want her to have any more erosions from her disease, because we think that once your body's taken bites out of these bones that it may be permanent. We're not sure. Some of these drugs are so amazing that we think we might be able to get some of this bone back, but it's certainly something we want to prevent. So Linda alluded to the diagnostic criteria for rheumatoid arthritis. More than 4 of the following must be present, so we kind of went into this. We talked about the stiffness in the morning. So the patients, that's the first question I ask. How long are you stiff in the morning? When you ask this question of a man, you have to be very careful. I do jazz hands, okay? I do this. How long are you stiff in the morning? Because they want to tell you another kind of stiffness. They're very proud of it, okay? So how long are you stiff in the morning? So you want to talk about joint stiffness, and the patients will tell you that they're stiff until they get out of a hot shower, that it takes them an hour or 2 to get the joints loosened up. Because they have so many of this pro-inflammatory hormone, their joints cool down while they sleep, right? So that's going to give you more of that gel phenomenon. And so it's more difficult for the patients to do their hair in the morning, get showered in the morning, do the activities that they normally do because they're so stiff. They're going to have more than 3 joints involved, and it's symmetrical. So the patients are going to tell you that they think they're crazy, because they'll tell you, I had a patient that described rheumatoid arthritis to me so classically. I thought she had looked it up in the book before she came in. She's like, I don't know what was happening the other day. She said, I just felt really bad. So I went and laid down on my bed, and she said, my shoulders started hurting so badly, I thought I was going to cry. So I laid there for a while, and she said, then it was my elbows. My elbows were killing me. Both of them were killing me. And then I got up and I went to the bathroom and I came back to bed, and then it was my knees. My knees were killing me. And then it was both of my ankles. So they think, surely to God, I'm crazy. It can't be rotating through my joints like this. It really can't. But it's very symmetrical. It'll be both hands, both feet, both knees, both elbows, both shoulders, both hips. If they have unilateral, so they have one bad hip, one bad knee, one bad foot, that's more like psoriatic arthritis or ulcerative colitis or Crohn's. If it's symmetrical, it's usually more rheumatoid arthritis, okay? And they're going to have rotating joint pain. They're going to have pain for more than 6 weeks. They'll have a positive rheumatoid factor, although Linda talked about 20% of the patients will not have a positive rheumatoid factor. And they can have those erosive changes on x-ray where it took a bite out of the x-ray. And they can have rheumatoid nodules, which are hard to differentiate from gout nodules. It's a big lump that they get, and you don't know whether it's rheumatoid arthritis or gout until you aspirate stuff out of there. So there's treat to target guidelines. Y'all don't need to know this unless you're in rheumatology. Basically, what this says is that every 6 weeks we should be reevaluating the patient, because what we found is that the patients who are treated earlier and aggressively tend to have better outcomes in the long run. Europe does a much better job than we do in America. So Linda works in a great institution where she has an early RA clinic. In Lansing, where I work, we used to have GM. GM closed a big part of Lansing. Most of the doctors in town left. So a big part of Lansing is very, very economically not doing well. And then we have Michigan State University in the other part of Lansing. So unless you're connected to Michigan State University or you've retained your job at GM, there's really not a lot of doctors in town. And so it's very difficult for us to get enough patients into rheumatology. The patients are waiting 6 months to get into rheumatology. And so there's this big delay in diagnosis, and there's big delay in treatment. Whereas in England, for example, there's nurse-run clinics, yay for us. So if you think that the patient has rheumatoid arthritis, you go to the nurse-run clinic. The nurses do the labs and the x-rays and do some workup on the patient. If the patient is definitely diagnosed with rheumatoid arthritis, they get straight into rheumatology. So the patients are diagnosed and treated a little bit more quickly. So that's what the whole treat to target guidelines were about, is about getting the patient treated as quickly as possible. We use this homunculus man to do a joint count. So nurses do the joint counts in our clinic too, and we use the scores on these joint counts to assess whether the patient's responding to the medications or not, right? So if the patient originally came in with 28 out of 28 swollen joints or 28 out of 20 tender joints, and then they're on a new medication, and you can say to the insurance company, since they've been on this medication, their tender count went down or their swollen count went down. That helps you with insurance authorization of these drugs, because insurance wants concrete numbers. And since Linda tells you that the rheumatoid factor is not going to go down and the CCP antibody is not going to go down, and 60% of these patients are not going to make a C-reactive protein or a SED rate unless they're obese or they have fatty liver disease or there is a secondary infection or something like that. A lot of patients don't make these inflammatory markers. Even if they have really bad RA, they still may be negative. And so the insurance company's going, so tell me, how do you know they have really bad RA? And unless you have X-ray damage, which is too far gone, right? Because we're not going to get that back. The insurance company is going to want to know, why do they need these more aggressive, more expensive diseases or drugs? I'm sorry. So that's why we do the tender joint count, and that's why I love that Vectra blood test. So any way that you can get across to the insurance company. The other thing is a hack score, which we use in our office, which assesses whether the patients can shampoo their hair, get in and out of the car comfortably, things like that. So how is it impacting their life? Complications of untreated rheumatoid arthritis. So I said earlier I was an intensive care unit nurse. I worked in a medical respiratory intensive care unit, very small unit, 6-bed unit, and I worked at a county hospital. So we had an 85% death rate in the unit that I worked in. It was, a long time ago, and so we didn't have a lot of treatments that we had today. So that's where I met my first patient with rheumatoid arthritis. I went to Grand Valley State University for my nursing degree, and the only thing I was taught in nursing school about rheumatoid arthritis was that it was the deforming one. That was the extent of my knowledge of rheumatoid arthritis. It was the deforming one. And so when I got report in the morning, and my patient was a 54-year-old woman who was a Mennonite woman. She was a very neat lady. Her name was Mary. And her primary diagnosis was rheumatoid arthritis, and she was on the ventilator. I was confused, right? Why is she on the ventilator when her primary diagnosis is rheumatoid arthritis and she's 54 years old? Well, come to find out, what Mary had was pulmonary fibrosis, and so that's what this X-ray illustrates. So pulmonary fibrosis, simplistic explanation, is a stiffening of the lungs. So instead of like rubber balloons, your lungs become more like brown paper bags. They don't oxygenate. They're not elastic anymore. The oxygen can't cross the barrier anymore. So it's pulmonary fibrosis. My rheumatoid arthritis patients accuse me all the time of wanting to upcharge their visits by listening to their lungs. Why do you need to listen to my lungs? My primary care physician does that. First of all, they don't go to their primary care physicians. That's the lie number one. Lie number two is they don't understand why we're listening to their lungs when they have rheumatoid arthritis. And what we're trying to do is make sure that it's not getting into their lungs, because that's what happened to Mary. So Mary had pulmonary fibrosis secondary to rheumatoid arthritis. So this is going to date me, okay? So Mary had been on gold for her rheumatoid arthritis, injectable gold, like your jewelry. So it was injectable gold. That was a standard of treatment back in the late 80s, early 90s. We didn't have a lot of other drugs. Methotrexate came into fashion about 1985. So she had only been on gold and steroids for the treatment of her rheumatoid arthritis. It was not unusual at that point in time. And so that's why her disease progressed so rapidly, and she ended up dying in our intensive care unit from complications of rheumatoid arthritis. So when patients come in and they try to be very, very stoic about, oh, my family has a history of rheumatoid arthritis and I can deal with the pain, and I saw the commercial and I don't want to get the cancer from the drugs, we have to really re-educate these patients that you're more likely to die because of the disease. And you're way more likely to die because the disease is poorly controlled. They have double the risk of cardiovascular disease. Double the risk of cardiovascular disease of people who don't have RA. So we are forever telling the patients to go get their cholesterol checked. Have you had your recent stress test? Because I had a 50-year-old patient who was a carpenter in our practice who dropped dead from a heart attack because his RA was so poorly controlled. They did an autopsy. He did not have plaque. He did not have a history of hypertensive. It was merely because his levels of inflammation were so high that he died from rheumatoid arthritis, heart attack induced complications. So rheumatoid arthritis can cause pulmonary fibrosis, deformity, disability, decreased quality of life, increased morbidity and mortality. It can certainly affect many different organ systems, dry eyes, dry mouth. It can cause Felty's disease, which is a liver problem. It can cause anemias. It can cause problems with your platelets. So it can do many, many different things, not just affect your joints. So this is not going to mean a lot to you. It's the ACR guidelines of how we treat patients with rheumatoid arthritis. Basically, it's an algorithm. So basically what all of these things point to is that you start with methotrexate first, okay? Methotrexate is the #1 drug used in the United States, Europe, and Canada for the treatment of rheumatoid arthritis. So you start the patients on something for pain and anti-inflammatory. You start the patients on methotrexate, if they're a good candidate for it. So they're not an alcoholic, they're not somebody who's going to give birth anytime soon, they're on appropriate birth control, you've done counseling. So patients who would be appropriate for methotrexate, and if in 12 weeks they're not doing significantly better, then you can advance their therapy to either a combination drug, which is what we used to use in the old days, Plaquenil, methotrexate, azulfidine in combination, plus steroids, plus an anti-inflammatory. So think about how many drugs the patients were on with rheumatoid arthritis. Plus, most of them have hypertension. Plus, a lot of them got diabetes from the steroid use. They were on a lot of drugs just for their disease state, and that became very cumbersome. So now we have the advantage of going methotrexate, and then if they fail methotrexate, we can go to one of our biologic drugs, which we're going to talk much more about. So again, the 2015 ACR guidelines for rheumatoid arthritis, they've changed only in that there's different biologics available, and still it's the same stepwise. You can go through and add either Plaquenil or azulfidine, or you can add a biologic drug. So Linda said earlier that different things can cause your rheumatoid factor to be positive, and that's so true. I had a patient in my practice, and I wrote an article in the Rheumatology Nurse newsletter, which Scott in the back edited to make it look like I really talk a lot better than I do. Scott does that. We write these things, and he makes them look really, really pretty, which is why that newsletter is so very professionally written. So I had a patient who was sent to me with a diagnosis of rheumatoid arthritis, and I picked up her chart because in the old days we used to pick up whatever chart was on next. We didn't have our own patients. Now I have all my own patients. And she was diagnosed with rheumatoid arthritis. It was my job to start her on methotrexate. I did that. Her liver enzyme spiked. I called her because I thought, uh-oh. So I called her. I had her come in. I thought we were going to have a conversation about alcohol abuse. That was my first go-to. So I was trying to have that conversation. You know, we're all nurses. I said, so have you been under any stress lately? She said, yes, I've been under quite a bit of stress. My husband has hepatitis C. After I collected myself, I said, have you been tested? She said, no. So I tested her. Her viral count was more than 1 million. She didn't have rheumatoid arthritis. Her rheumatoid factor was positive because she had hepatitis C. That also happens in HIV patients. Their rheumatoid factor will be positive. If they have cancer, their rheumatoid factor will be positive. So you got to make sure you know what you're dealing with before you start dealing with it. So treatment. In the old days, when I started working for Dr. Beals 15 years ago, everybody got an anti-inflammatory. Everybody. Osteoarthritis, fibromyalgia, psoriatic arthritis, rheumatoid arthritis, everyone was on an anti-inflammatory. That was great until people started living above the age of 85 and they had no kidneys left. So we usually use the anti-inflammatories now early and aggressively, and then we try to pull back. I try to get my patients to cut down the doses that they use every day because we want to spare those kidneys as much as we can. So we use them early and aggressively, and then try to have the patients use as little as possible. But certainly if they're having a bad day. I'm from Michigan. The weather changes about every 5 seconds. I can't believe you live in paradise. I'm really, really glad that you all live in paradise. You should come. In the morning, it'll be 30 degrees when I'm walking the dogs. In the afternoon, it can be 70. So we can have a 40-degree shift in weather in the same day, and it's not unusual. It'll snow in the morning. It'll rain in the afternoon. It's just crazy. The weather is constantly changing. And my patients are constantly flaring because of the changes in the barometric pressure. Disease-modifying agents. So these are your DMARDs, your disease-modifying oral agents for the treatment of rheumatoid arthritis. The only thing you need to remember about these are they're like your superhero shields. You know how every superhero has a tool that they use, like they have a shield or a sword or something like that. This is what these are. These are your armory of weapons. So I can combine these drugs together to make the patient better. And all of the biologics, which are on the next page, different biologics, we'll get back to that. All of the biologics work better if you pair them with a disease-modifying agent. So it's like the biologics, your superhero. It's the super drug that we have to treat this disease process. But all of those super drugs work better if you pair them with one oral. Why is that? Because your body can develop antibodies against medications, right? So your body's real tricky. So you can be taking Humira and everything can be really, really great for several years, and then all of a sudden it stops working. Well, we try to trick the immune system, and if we put you on Humira plus methotrexate, your immune system has a lot more difficulty in figuring out how to fight off two drugs at the same time. That's why compliance is super important, and patients who are on methotrexate are terribly compliant. because they don't like the way it makes them feel, because they're worried about potential side effects, because they experience hair loss or oral sores. So it's super important that they tell us whether they're taking their medication or not, because it's less likely their biologic's going to work if they're not paired with an oral. We do have patients on monotherapy. I have patients that are alcoholics. I have patients that are diabetics. I have patients that are still trying to get pregnant or who are actively having babies. And so they're much more likely to be on monotherapy, where they may just be on a biologic alone. And that's fine now that we have 8 drugs available, gonna be 12 soon, because if one stops working, I can give the patient another one. In the old days, it was scary, because if the one stopped working, what else did I have to offer? So there's different types of biologic medications. There's a tumor necrosis factor. Remember, I told you everybody in this room has tumor necrosis factor in them. Otherwise, we would all have tumors. Tumor necrosis factor is in your bloodstream right now looking for cancer cells. B cell inhibitors, there's JAK inhibitors, there's T cell inhibitors. They all work differently on the immune system. So they're like shoes, right? I like these pretty ones, and I hope that if anybody finds me dead, they'll bury me in these, okay? These are my favorites. Some people like Clark's, some people like Merrill's. That's the same way with these biologic drugs. The patients have to trust us a lot, because I can put you on Enbrel and I can put your twin sister on Humira, and one works for one and one doesn't work for the other. It's very strange. Even though they're both TNF inhibitors, they don't all work the same for some people. So please encourage your patients, if they're on these fancy schmancy medications and they're not working, to tell us so we can switch them to another one. It may take 6 months sometimes for these medications to kick in, and so they have to be in there with us trying to make sure that this is not the right drug, and that we can get the insurance to try a different drug, and so we can try that drug for a while. So this is the biologic table, very complicated, but basically I just wanted to illustrate to you that there's lots of medications available. The trade names are on the left out here, how they work, their mechanism of action, and how they're dosed. There's an IV nurse in the audience. We dose some of them IV, and some of them are subcutaneous at the patient's houses. Most of the companies have nurses that'll go to the patient's home to assist with injections, injection teaching, and injection training kind of stuff. Some of the patients go to the hospital for IV infusions. Some of the patients have IV infusions at their rheumatology office. So it just depends on the drug. So contraindications. This list keeps getting a lot shorter. I just wanted to have a brief discussion about this. So not everybody is a great candidate for a biologic drug. The patient that I would tell you is a rough candidate for a biologic drug is somebody who's sick all the time. So if they tell you that they're on an antibiotic a couple of times a month, that's going to be a tricky one. But having said that, patients with rheumatoid arthritis who have poorly controlled disease tend to be sick more. Think about your poorly controlled diabetics. They're sick more frequently, right? Same thing with rheumatoid arthritis. Patients with rheumatoid arthritis before the biologics came out were in the hospital all the time, you probably remember, because they were sick and they needed pain control and they needed IV steroids and things like that happen. Now that their diseases are better controlled, they tend to get sick less frequently, and so you have to remind the patients of that. But if they're one of those patients who has hypogammaglobulinemia or they have low IgG, they may not be the best candidate for this type of therapy. If they've ever had hepatitis B or C, you've got to proceed cautiously. I know Lynn Calabrese at Cleveland Clinic, my friend Betsy, and I wrote the last chapter of the book together. It's on HIV and arthritis. So Len Calabrese has patients who have finished Harvoni for their hepatitis C, and they still have rheumatoid arthritis, like real deal rheumatoid arthritis, and then we can treat them with whatever we want to treat them once that we know that their hepatitis C viral load is down. So the rules have changed, and certainly there are patients who have HIV that are on these biologic drugs now. Initially, when the biologic drugs came out, we were like, no, you can't do that. Oh my gosh, they're going to kill them. They're going to have some horrible infection. But now that HIV is a chronic illness, rheumatoid arthritis is a chronic illness, we've figured out that we can combine the drugs safe. They're really close to remission. So we're going to quickly go through the drugs, and I'm going to stop talking, I promised. Inhibitors, the most important thing is they're pregnancy category B. So when I'm trying to get a patient, desperately trying to get a patient to try these medications, I say, you know, you can take it in pregnancy. See the pictures on the wall? Cassandra had a baby on Humira. She breastfed on Enbrel. So I have pictures of my patients who've had babies on these medications and who breastfed on these medications to give the patient some level of comfort with taking them, because they are not going through your organ systems. They're not going through your liver. They're not going through your kidneys. They're going right through your bloodstream, taking out the level of inflammation and getting out of your body. So they're incredibly safe if well monitored. So we just have to tell the patients that. So every This is a black box. See, it's the package insert. This is a black box warning. I was trying to help you visually there. Okay, so that's your black box warning on the tumor necrosis factors. So the number one question you're going to get from your patients is, I'm not taking that because I'm going to get the cancer. That's what they say to me all the time, the cancer, okay? Just like the Facebook, all right? So the patients are worried about getting the cancer. And initially, they'll take the drugs, and Linda knows this. They'll take the drugs because they're so desperate. They can't wash their hair, okay? They're using a walker. They can't get in and out of the car. So initially, they may take the biologics, and then 6 months later, when they feel better, they stop taking them because then they worry about getting the cancer. And so this is where we need your help. So what we're going to do, because I'm a Spartan from Michigan State University, okay? So I have a degree from there too, but that's a different story. So Michigan State University just beat University of Michigan. Is kind of a big deal, all right? So Spartan Stadium, we're going to pretend like only holds 10,000 people. So we're going to put 10,000 people in Spartan Stadium that have rheumatoid arthritis. Statistically, 4 people are going to get lymphoma out of that whole Spartan Stadium. So if we put 10,000 people in Spartan Stadium that don't have rheumatoid arthritis, statistically 2 people are going to get lymphoma, okay? So the increase went up when they had rheumatoid arthritis from 2 to 4, okay? So we put 10,000 people in Spartan Stadium, everybody has rheumatoid arthritis, and everybody's on a biologic. Statistically, 4 people are going to get lymphoma. So the rate didn't increase when they're on a biologic. As a matter of fact, some cancers have gone down because now, since Enbrel's been out since 1998, we can look back on retrospective studies. Solid cancer tumors have been on the decline in the patients who have well-controlled disease. So it goes back to that we want the patients to be in remission. We want them to have well-controlled disease. So you can reassure them that the cancer risk, the lymphoma risk, is not from the drugs. It's from the disease process itself. So Orencia is super safe. It's a pregnancy category C, so it's kind of different than the TNF inhibitors, but the safety profile, you notice it doesn't have a black box. So my patients who have had histoplasmosis, because I live in the Midwest and you get histoplasmosis from bird poop, playing with dirt, okay? So my patients who've had histoplasmosis or weird fungal infections, things like that, if we're worried about safety, we use Orencia. Actemra is an interleukin-6 inhibitor, again, pregnancy category C, and again, increased risk of infections on this drug. I tell the patients, I have patients who are ICU nurses, you're not going to get sick any more than you used to, but when you do get sick, I want you to take an antibiotic, I want you to go to your primary care physician, I want you to address it very quickly. I have patients that are going to get sick more frequently than you used to, but when you do get sick, I want you to take that antibiotic. I want you to go to the doctor. I don't want you to wait 2 weeks and be coughing up green phlegm and have fever and chills. That's not a good idea. Rituxan is a B-cell inhibitor. The joke is you can't die in this country without being on Rituxan once because they use Rituxan for everything, right? Lymphoma, they use it for non-Hodgkin's lymphoma. They use it for all kinds of leukemias. We use it for rheumatoid arthritis. It's being looked at for lupus. It's being looked at for Sjogren's. So Rituxan is great because it suppresses the immune system. It is chemotherapy, but it doesn't seem to kill off enough cells to really immunosuppress the patient. So it works on kills the bad guys and leaves the good guys behind. It certainly has a black box warning, and it's something that needs to be closely monitored, but it's 2 IV infusions a year. So if your patient's traveling from 3 to 4 hours away, this may be a good option for them. They get 2 IV infusions a year, and their rheumatoid arthritis could be controlled, which is pretty amazing. So Xeljanz is not really a biologic. It's a kind of a non-biologic biologic. It's the first pill we've had for rheumatoid arthritis. I put it on the biologic because it can be added to methotrexate, and it's the first one of its kind that's a JAK inhibitor. So it works on the bone a little bit differently than some of these other ones do that work intracellularly or extracellularly. JAK works intracellularly. And certainly it has the same black box warning with reactivation of TB and infections, and it's a pregnancy category C. But if your patients absolutely say, I'm never taking a shot or I'm never taking an IV, that this may be an option for them because it is an oral tablet. So these are some of my patients. Mary's had 7 hand surgeries. Certainly those are rheumatoid arthritis nodules here. Oh, I can't even tell you about this lady. She's so non-compliant, it's ridiculous. But that's what happens when you're non-compliant. So the patients, I keep these pictures on my wall in my patient rooms. I have these 2 big collages because they're great for making patients do what you want them to. Because they say, well, at least my hands don't look like that. And I say, well, they won't look like that if you listen to me. Okay, you have to keep coming. you have to keep taking your drugs in order to keep that from happening. So I think we're going to get ready for it. Mary was still working at the hardware store up to about 2 years ago. This is a rheumatoid arthritis nodule, and she literally has no joints left. They've all been completely dissolved from the rheumatoid arthritis. So we're going to get to more patients. More questions. Will I need to take this medication for the rest of my life? Are you ready? Are you still awake? Are you going to put your answers in? You're almost done. You're almost ready for dessert. Probably not. Once we get to your RA into remission, we'll safely taper off your therapy. Probably there's some evidence of drug-free remissions, but that's limited to a select group of patients. Sorry, but yes, RA is a chronic disease. Now, I didn't really help you with this earlier, so there are many right answers to this question. We'll just tell you that. Are you there? Are you ready? Okay. Woo! Look at that. C. Sorry, but yes. But actually, in Europe, they stop them all the time. So the patients in Europe get to take the biologic for 3 to 5 years, and then they're stopped off the biologic. And 50% of the patients that are treated early and aggressively actually stay in remission because they're treated so early and aggressively. So if you catch the rheumatoid arthritis early and the patients are compliant with their medications, 5 years, they may be able to pull back off of some of their therapies or completely off. I've had a lot of patients that have been able to spread out their drugs, but I have had 1 or 2 patients over the years that have been able to completely stop them. But most of the patients stay on the drugs forever. What if I want to get pregnant? A, that's fine. None of the drugs we typically use to treat RA are incompatible with pregnancy. B, that's fine, but we may have to adjust your treatment, especially if you're taking methotrexate or leflunomide. C, that's fine, but you'll have to stop taking all of your medications for RA. Or D, it's a bad idea. There's a number of dangers for RA patients to want to conceive. I feel like I should play the Vanna music. Put your answers in, please. Okay. It's fine, but we would have to adjust your treatment, especially taking methotrexate. Or methotrexate's a big no-no. You can't get pregnant on it. You're going to have some serious fetal deformities, okay? That's not even messing around. Leflunomide stays in your bloodstream for 2 years. So you take a leflunomide, it's stuck with you for a couple years. There's been babies born on it. There's been babies born on methotrexate. There's an Otis study right now going on looking at long-term effects of this, but it's not something that we recommend. If the patient is going to try to get pregnant, usually we use Plaquenil. We can use Imuran, and we can use the biologic drugs, okay? So, soapbox for me. So I have a patient the other day who's had gastric bypass. I'm from Michigan, okay? We have a lot of patients who have a gastric bypass, and I did an article on gastric bypass patients because I'm really interested in obesity and arthritis because of the connections. I have a patient that's had gastric bypass, and she wants to get her pannus taken care of, and she wants to get her hernia taken care of. So she's having surgery to get done. So she goes to see her. She comes in and sees me, and she says, how long do I have to be off my medications? And I said, well, actually, the last American College of Rheumatology, you don't really have to stop your Humira. If your surgeon's really, really nervous for 2 weeks before, maybe 1 to 2 weeks afterwards, but I don't want you to be off of it for very long, and the methotrexate 1 week before you're off of it, okay? So she comes to me yesterday. She can barely walk. Her daughter's in the hospital. Her surgeon said if she was not off her drugs for 6 weeks, all of them, her anti-inflammatory, her methotrexate, and her biologic, that he would not do surgery on her. He said he did his own research. I said, was that Google? Because he didn't call me to ask me what my recommendations were or what the most updated recommendations from the American College of Rheumatology. And I was just livid because he could have killed her. She's an obese diabetic who has really bad rheumatoid arthritis that's never been well controlled. She's barely in remission on the drugs that she's on, so double the risk of cardiovascular disease, right? So she's off her medications for 6 weeks, and she's going to undergo surgery, and her daughter's in hospital. What kind of risk factors did she have? Plus, her risk for infection postoperatively is super high because her inflammation's been poorly controlled. So please be very careful about the patients stopping their medications. You want to really consult with your rheumatologist and see what their guidelines is, but less is more. You don't want the patients to be off these drugs long term. Certainly if they have some kind of IV antibiotics because they have some kind of horrible infection, we're off the drugs. But most of the time we're able to maneuver around those drugs. Am I going to get cancer from my biologic? Hopefully you'll get this question right. I have 50% greater likelihood of developing certain types of cancers than the general population. You have 25% greater likelihood of developing certain cancers than the general population. It does not appear that biologic therapy adds to the normal background at risk of cancer in patients with RA, or we don't really know if RA impacts the risk of developing cancer. Okay, enter your scores. I'm from Michigan, so it's 3 hours later there. So we're going to keep doing the T, okay? Okay, you ready? So 76% said C, it does not appear that biologic therapy adds to the normal background risk of cancer. Woohoo, you all win. So it's the disease, right? It's the disease, it's not the drugs. Are there herbal therapies? I love this question. Are there herbal therapies? Luckily, the doctor that I work for used to be a nurse, and she's all about the vitamins. The vitamins are great. Let's do vitamins. But we have to do vitamins in conjunction with, right? Okay, so enter your absolutely not. Many herbal treatments will actually make you feel worse. While it's unlikely to hurt, there's no compelling evidence. Or yes, there are some herbal supplements that have been shown to help. I gave you the answer. Are you still awake? Enter your answers. Play along. Okay, B. Well, it's unlikely to hurt. There's no compelling evidence that it helps. Glucosamine, I put everybody on it. It works. It works for me. It works for elderly people. Glucosamine is just fine. And I like the plain old glucosamine. My patients take turmeric. That's fine. I love turmeric. It's an herb that helps with inflammation. Ginger, I've heard of all kinds of things that help. Cinnamon, great. Honey, I'm a big honey fanatic myself. Honey helps with all kinds of things, acid reflux, things like that. If your patients want to take herbal supplements, that's fine, as long as they're not like the Cambodia one. What is it? I call it Cambodia. It's a country, but it's that one that Dr. Oz talks about, weightless. Garcinia, that one, thank you. Because that one's liver toxic, and we have them on methotrexate, and then they're taking antifungal from their podiatrist, which happened to me the other day. So it's really bad. You got to be careful what they're putting in their mouth and that they're telling you what they're putting in their mouth so that we can monitor for the side effects, okay? Thank you for coming. It was so great. I know you gave up a Friday night to come out here and get educated. That makes a huge, huge, huge difference to us. I really, really appreciate it. Thank you, thank you, thank you. If you have more questions, just ask.
Thank you all. We're all East Coasters, so it's 11 o'clock at night for us right now. And the night's still young. See, it's like we get bonus hours when we come out here to beautiful San Diego. Well, first off, I want to say goodnight to our live stream. Thank you for the viewers that joined us tonight and the replay, and so we appreciate that. You can watch this again on the RNS website, rnsnurse.org. Also, sign up to receive the free Rheumatology Nurse Practice newsletter. We'll mail that to you for free. It's a great evidence-based, peer-reviewed, it's almost like a mini journal. Shout out to Scott Cover, our medical writer, and our medical writer team for helping us put that together. So thank you for the live webcast. So for everyone